So that's what postprandial glucose means over there. The red line, if you just measure blood sugars, you'll see that your blood sugar 2 hours after your meal is no longer at the right range. What's the right range? Less than 140. Might be 150, 160, and for years and years, we ignored these numbers. And they're still largely ignored because they don't look that alarming. So if you do what I do, which is look at blood sugars in the hospital all day long, blood sugars 150, 160, they go home with no diagnosis of glucose intolerance. Didn't matter in the hospital. Oh, maybe they were sick, maybe there's something else going on. But when you go back and look, when they come in with full-blown diabetes 2 years later, you go back and look, their sugars haven't been normal for 3 or 4 years. They just haven't been that high. Dr. Green and I used to work at the VA together 1,000 years ago. In the old Loch Raven VA, the urology clinic measured a glucose and a creatinine on every single patient in the urology clinic. This is the VA, after all. Every single patient in the VA has a prostate problem. So it was every single patient in the VA was in the urology clinic. And this one urologist got the same glucose on everybody for years and years and years. You can go back and see these glucoses for decades and watch them gradually rise year after year after year until they finally ended up in diabetes clinic. So really could see this evolution of glucose over time. Once the insulin supply starts to fall down and you end up with decreasing beta cell function, then the fasting blood sugar starts to rise as well. And when you reach the artificial cutoffs that the ADA has set for diabetes, you're now diagnosed as diabetes and not pre-diabetes. Artificial cutoffs, fasting blood sugar that exceeds 126, or a 2-hour post-meal blood sugar that exceeds 200. Or now a hemoglobin A1C that exceeds 6.5. We tried to make life simple in terms of making the diagnosis. Glucose tolerance tests we still do, but in a very select population, just the ones who really fall in the crack someplace and you're not quite sure. If you live long enough, beta cell function will get worse and worse and worse. Sugar will get higher and higher and higher. And somewhere in here, you might need insulin. I had this discussion today with my physician's assistant who said, how can you call somebody who used to have type 2 diabetes type 1 diabetes? I said, well, if their beta cells don't work at all anymore, they become type 1. And so we have a patient in the hospital who came in on glyburide alone, a half of a 1.25, according to the history anyway. His hemoglobin A1C in the hospital on admission is 14.8, which means an average blood sugar at home of about 500, something like it. In the hospital, he needs 10 units of insulin, that's all. He's a type 1. I don't care what he was before, he's now a type 1. So you treat people by the way they behave. So this is the normal evolution. Type 2 diabetes is a progressive illness with a progressive decline in beta cell function over time. We need to intervene in here to try to preserve beta cell function to avoid this progression. Do we know that we can do that? Yeah, we do. We have lots of studies that demonstrate that various interventions, medications of various sorts, but primarily diet and exercise, we can stop this from happening. In the diabetes prevention program, they took patients who were here, in this little area, high post-meal blood sugar but not diabetic, and randomized them to diet and exercise versus standard care, and plus a bunch of medicines. The ones on diet and exercise got counseling every month for, I think, 3 years. And what was the net result of all this effort on the part of the dietitian and the physiologist? They lost 8 pounds and exercised 120 minutes a week walking. And that little bit of weight loss, 8 pounds, and that little bit of exercise resulted in a 60% prevention of progression of diabetes. You didn't have to become Michael Phelps and swim 6 hours a day. You didn't have to become Rafael Nadal and play tennis 6 hours a day. You just had to walk 30 minutes 4 times a week and lose 8 pounds. So it didn't take that much to make this occur. The medicines did far less well than did this little bit of exercise and weight loss. They did do something. So we know we can prevent this with that combination. No drug has ever sought this indication. So if you're going to take it for pre-diabetes, it's an off-label use so far in time. Not that we don't know it doesn't work, but they've never actually achieved approval from the FDA. Down here at the bottom is what you're trying to avoid. If your blood sugar is 150 to 200, are you going to feel bad? No, you're going to feel fine. You're not going to notice this at all. But if you stay in this range for years, these glucose levels build up damage in your blood vessels. So we have an accumulation of microvascular change and macrovascular change. Microvascular are the complications that you know that relate to diabetes. Diabetic retinopathy, so you have damage to your eyes. Diabetic neuropathy, which is damage to the nerves, which starts with numbness or pain in your feet, or erectile dysfunction for men, or stomach doesn't empty, or diarrhea, or a long list of things that you'd rather not have. Or diabetic kidney disease, resulting in progression to kidney failure and dialysis. Macrovascular disease is heart disease and stroke or circulation problems. 75% of diabetics end up as the cause of death in this category. That's what you're trying to avoid. And you want to avoid this back at this end if you possibly can. So the islet cell that makes the insulin also makes glucagon. So there are two hormones involved in insulin secretion here, or in glucose control. The beta cells here make insulin, which promote glucose uptake by that fat cell in the muscle cell and suppress the liver from making too much glucose. Glucagon does the reverse. It makes the liver make more glucose, and this is too high also in diabetes. So this is too low, and that's too high. We have medicines that take care of both of those things if we possibly can get there. So this is a study in the Pima Indians, which is the best demonstration of why diabetes progresses. Pima Indians live in the southwest of the United States. The same Pima Indians live in Mexico. Same genetics, exactly. Pima Indians in the southwest live on a reservation, and they run casinos. So they don't have to work too hard. The ones in Mexico are dirt farmers. They have to work like crazy. The Pima Indians in our country have a rate of diabetes that exceeds 50%. The Pima Indians in Mexico don't get diabetes at all. And when they followed these people over years, the ones who did not progress could make more insulin. This is as these patients got fatter and did less exercise. The ones who developed diabetes, their insulin secretion fell down. So the insulin resistance was the same in both groups. The ones who got diabetes was because the beta cells couldn't take it anymore. So what happens in type 2 diabetes? So this is looking at glucose after a meal, okay? This is what happens in diabetes. Your blood sugar goes up dramatically and takes a long time to come down. And what happens in type 2 diabetes is not only are you taking in the glucose, but over here, you're still making glucose even though you just drank this sugary sweet drink to test your glucose. So clearly the glucagon levels are inappropriately high in type 2 diabetes, and you're making glucose when you really don't need to make glucose. This is data from United Kingdom Prospective Diabetes Study, which says once you've made the diagnosis of diabetes, you've already lost 50% of your insulin secretion by the time the diagnosis occurs. Ralph DeFranco says it's 80%, but it's at least, you really want it to be found back here someplace, not when the things have already gone by. And this is similar data